A very good evening to one and all. I am Arpita from the IGCP group. Sepsis remains as one of the most challenging and life threatening conditions in modern medicine, affecting millions of people worldwide every year. It's a complex syndrome caused by the body's overwhelming response to infection, which can lead to tissue damage, organ failure, and ultimately death. When sepsis progresses to multi-organ dysfunction, the stakes rise even higher, requiring rapid, precise intervention and critical decision-making at the bedside. As we gather today to observe the World Sepsis Day, our focus is on understanding sepsis from a practical, clinical perspective. In this session, we will explore sepsis and multi-organ dysfunction still from the bedside, where we will dive into real-life cases, examining the early signs, treatment challenges, and the critical care strategies that can make the difference between life and death. And yes, it's an honor for me to introduce an esteemed expert in the field of medicine and critical care, Dr. Abhiral Roy. He is the System Director of Critical Care Services at CarePoint Health in the USA, with extensive experience in managing critically ill patients and leading healthcare systems. Dr. Roy's expertise has been instrumental in advancing patient care and outcomes across multiple hospitals. So, sir, with this very brief introduction of yours, now I would like to hand over the session to you. Over to you, sir.
Hello, hi, thank you everyone, and welcome to World Sepsis Day. Now, as I'm sure you're all aware, sepsis has been recognized as a cause of disease and malady from the times of Aristotle and the times of Hippocrates, right? Back in the early 500, 600 BCs, where at that time, however, we did not have the germ theory of health. At that time, it was thought that it was bad odors or bad air, miasma as they called it, that is responsible for infection. And then as time has progressed, we know that sepsis is usually due to microorganisms, most commonly bacteria, but in very at occasions it can be from viruses as well, and rarely fungi. What we're going to talk about over here is the difficulty that we get in some cases of sepsis, where you may not have you may not necessarily have a clinical diagnosis or organism in your investigation, so you have to rely on a clinical diagnosis. Another one being infections complicated by patients with underlying metabolic issues. By metabolic, I mean inherit, probably something that is genetic in origin and not necessarily acquired, that needs to be often worked up. And third, very often when you get one type of sepsis, it can often morph into a secondary type of sepsis, a secondary infection that we have to learn to catch and identify and then treat appropriately. With that being said, let's get started immediately. So our first case is altered mental status. Now these cases were in India when I was working for a hospital that provided care to in the not in a urban area but in a semi-urban area, and a lot of these people were from not very good background families, so our ability to do advanced testing and very aggressive testing was limited, as I'm sure is the case that a lot of you face as well, right? Families with limited means to be able to pay a lot of money for multiple high-end investigations or multiple labs. So a lot of these cases had to be managed with the clinical diagnosis became more important than the microbiological or the investigative diagnosis. So our first patient is a 50-year-old male who this case was seen in November 23. He actually presented to my clinic earlier that day with just a headache. He walked into my clinic and he was absolutely fine, had a headache and low grade fever for 2 days. And I told him, get a CT scan of your head. I didn't think anything else of it. And then maybe he was walking out and suddenly stumbled and became very disoriented and dizzy and confused. So instead, we he went to the emergency room while he was waiting for a CT scan in radiology. In the emergency, his vitals showed blood pressure 140/80, heart rate 87, respiratory rate 20, but he had a sudden drop in GCS of 11/15, and his blood sugar levels was 289, which is so it's not hyperglycemia. Not following commands, not able to answer questions, he's suddenly very disoriented. We got an immediate CT scan of the brain, which did not show anything. We then advised an MRI study and a CSF study. And as you can see on the CSF, you see a high number of WBCs, right? 240. Remember, CSF less than 10 WBCs. Anything more than 10 is concerning. We also see a sugar level of 134. Now, even though this looks normal, remember what we saw over here? The sugar level is 290. Your CSF sugar should be roughly 60 to 70% of blood sugar. So this is slightly on the lower side. This is less than 50%. So this is concerning. And of course, there's an elevated protein level. 90% lymphocytes with 10% PMNs, which is also called polymorphonuclear cells, or basically leukocytes. So, so lymphocyte predominant, elevated ADA level at 156. HSV PCR of the CSF study was negative. The MRI brain, however, showed bilateral T1 hyperintensity, which is cerebral edema in the temporal lobes. And when you see cerebral edema in the temporal lobe, you think, is this viral meningitis? However, given the high ADA, this could also be tuberculous meningitis, correct? So a patient immediately started on HRZE, AFB culture, ZN stain, and CBNAT testing was immediately sent for the CSF fluid. As you can see, the CT scan of the brain just showed a little bit of sinusitis, chronic sinusitis, nothing else. MRI of the brain suggests a viral encephalitis. However, then we had that ADA. So we go with tuberculous meningitis, viral encephalitis, partially treated bacterial meningitis. Highly unlikely over here because our patient has not taken any antibiotics. And of course, this patient also has a sepsis syndrome and multi-organ dysfunction, with not multi-organ dysfunction, but single organ dysfunction. You could ask me, what is the organ dysfunction over here? The organ dysfunction over here is CNS, central nervous system dysfunction, drop in, drop in patient mental status. GCS is 11 on 15. So this patient is having, in addition to meningitis, which is very very focal, he's also having encephalopathy. So what do? We start initially on meropenem, vancomycin, acyclovir, dexamethasone. Remember, we don't have the diagnosis on the first day. CSS has just been sent, CT is done, MRI is done. We are waiting for the MRI report. So initially, however, the ADA comes back relatively quickly. So we go ahead and start broad spectrum therapy with antibiotic, antimicrobial. We add dexamethasone because of bacterial meningitis and especially TB. You get a lot of secondary inflammation from the body's immune system attacking the bacteria, and very often gets worse when you add the antibiotic, because as bacteria die faster, um, you get the immune response can often flare acutely, and this can cause a lot of arthritis and thrombosis, especially in TB, in the basal blood vessels in the basal cisterns. So you can get a lot of brainstem focal neurological deficits of the brainstem. To try to reduce that, we add dexamethasone. We added a tablet ATT, so anti-tubular therapy, with HRZE along with pyridoxine. So HRZE, if you all remember, is isoniazid, rifampicin, etham, so isoniazid, rifampicin, pyrazinamide, and ethambutol. And we added some quetiapine because this patient was confused, restless, was kind of moving around and not, you know, interfering with care. So, what did we continue this therapy? His ZN stain was negative, his CB-NAT was negative. However, we repeated the LP on day 5, which shows a WBC count of 60, sugar of 77. And by this time, we had also started him on insulin management. So his sugars were much better. Proteins are still high, but protein takes time to go down, right? However, he requested discharge on the 14th of November just because, again, financial considerations for him. So at which point we had given meropenem meningitis dose, which is 2 grams 3 times daily for 5 days. We were continuing the DEXA, which we did a gradual taper. We continued him on the HRZE, tablet quetiapine for 25 milligrams at night. At discharge, he was now awake, following basic commands, following basic tasks. GCS had improved to 15/15. oriented but still a little confused. And we discharge him on ATT and steroids with instructions to continue therapy and to follow up, which he never really did. So he was lost to follow up. So you might ask, why do I present this case, right? And this case is very, very classical clinical diagnosis. Remember, we are in India, right? TB should never be out of your list of differential diagnoses, right? And remember, TB is a clinical diagnosis as well. Of course, there is the microbiological diagnosis, there is the biochemical diagnosis. But however, if at any point you think this patient has TB, you can always initiate ATT on the basis of clinical judgment. This is a factor. This is there in the national tuberculosis treatment guidelines as well. That clinical judgment is a big part of making a TB diagnosis. And as you can see, we started this patient on ATT, and they responded immediately, even though we never cultured any virus. The other reason that we also bring up this case is that your imaging can deceive you. It might look like viral meningitis, but if you're not going to find any virus particles, you know you don't know what's going on. So always consider TB in your diagnosis of meningitis. And if you have severe meningitis, it's better to start ATT than to be late with TB, just because TB has a very, very high rate of neurological complications. Moving on to a second case is, weird abdominal pain. So, this is a 48-year-old female who comes to the ED with severe respiratory distress. She has bilateral pedal edema. She has abdomen distended, the ascites present, which is odd. And she has severe weakness. Vitals show normal blood pressure 160 by 80, heart rate is in the 120s, respiratory rate is 39, SpO2 92% in room air. Temperature is 98.4, GCS we can see over here is low, E2, V2, M5, so that works itself out to 9 on 11 or 9 on 15. Correct? At which point you're like, what's going on? Is this person having respiratory distress? Why? Is there like is this patient liver failure because that pedal edema with abdomen distended? Does this patient have heart failure? Any heart condition? What's going on? You get an initial ABG in the emergency room, shows a pH of 7.52, so that's alkalosis. PCO2 of 19, which is implies respiratory alkalosis. Over here, you can see severe hyponatremia, sodium of 108, chloride of 3.6, potassium of 3.6, and chloride of 15.5. Now, 15.5 chloride implies, a 15.5 bicarbonate implies metabolic acidosis, correct? So, this patient actually has mixed disease. This patient not only has respiratory alkalosis but also has metabolic acidosis. Now, we have to figure out if there's compensation or not, but that's a topic for a different day. We send initial blood work. So the WBC count 29,000, sodium 112, hemoglobin 10.7, urea 73, creatinine 2.6. So this patient also has AKI, very high CRP at 94. And you can see AST, ALT, alkaline phosphate, they're all high. So this patient is clearly having some sort of hepatitis as well. Albumin is 2.4. So probably is this more acute and chronic type disease? Because remember, albumin, if it's in the albumin will always start going down the moment you have any critical illness or any severe illness. But normally, remember, albumin, what the level of albumin is normally like 3.5 to 4.5, correct? So you expect if it's acute disease, maybe 3.3, 3.4, 3, but to be down to 2.4 implies a prolonged state of poor nutritional status. So then you're like, is it acute or chronic, or does patient have poor nutritional capacity? And over here, then you see total bilirubin comes back at 8.75 and conjugated bilirubin comes back at 5.0. So this patient is started on NIV, more specifically BiPAP in the emergency room for the work of breathing. So we give furosemide, 20 milligrams IV stat. For fluid overload versus hypertensive urgency, because we are not sure. Remember, the blood pressure is still a little high, 160 by 80. It may not be that high for most people, but if you're somebody who's not used to a high blood pressure, it's normally running like 110, 110 systolic, and you suddenly increase this person's blood pressure to 160, they can most definitely have a hypertensive crisis. Also, the other page thing is, if you have some sort of cardiac abnormality and you suddenly their blood pressure goes up suddenly for any reason, it can often precipitate a hypertensive emergency where they develop acute pulmonary edema just because the heart fails immediately. Anyways, after giving Lasix to this patient, the blood pressure now drops to 70 over 40. What do? We immediately started this patient on norepinephrine or noradrenaline 4 ml per hour. Sodium bicarbonate 50 ml bolus was given. We started this patient on 3% saline as well for the severe hyponatremia at 15 ml per hour. We started this patient empirical antibiotic therapy of doxycycline 100 milligrams twice daily, as well as piperacillin tazobactam 2.25 grams every 3 hours, every 8 hours, that is 3 times a day. And she was immediately given back 2,500 cc's of ringer lactate along with 40 grams of IV albumin. You might ask why albumin? Because we saw her serum albumin level, as you can see over here, was quite low, implying that albumin may be useful in helping this patient's fluid resuscitation. What's our diagnosis, right? Is it septic shock? Of course, one of all you always consider it. That's our topic of the day. Pulmonary edema, possible, yes. Pneumonia, quite likely. Fluid overload, yes, this patient has AKI, distended abdomen, pedal edema, and severe hyponatremia. So maybe we do have, true hyponatremia. So we're gonna try to figure out the cause. So we get the HRCT of the chest, which shows cardiomegaly and features of congestive heart failure. However, there are also features of atypical pneumonitis in bilateral lung parenchyma and a few mediastinal and bilateral axillary lymph nodes. Usually, when you ever see bilateral mediastinal lymph nodes in a patient with pneumonitis, those are usually reactionary. Reactionary meaning there are lymph nodes that are enlarged due to the presence of the infection. As you can see over here, we have 29,000 white count, normal platelet count on the right side, and the hemoglobin level that's more or less decent. We see labs here, we see the sodium at level at 112, we see the high creatinine, and along with that, we see this abnormal liver function. Um, Amylase and lipase are normal, so because of the abdominal pain, we ruled out pancreatitis over here. You see the predominant conjugated hyperbilirubinemia, which implies that this is quite likely some sort of liver dysfunction. But because hyperbilirubin unconjugated, sorry, conjugated bilirubin is high, so this means there's probably some sort of obstruction. But because unconjugated is also high, you could also think that there is some component of hepatitis or uh, hepatic dysfunction. CT scan of the brain every time you have a confused patient, you get one, is unremarkable. No evidence of any acute stroke. So, of course, given the fact that this patient had signs of liver dysfunction, you get the ultrasound of the liver, which of the abdomen, which just shows an enlarged liver with grade 2 fatty changes, which is not that unremarkable. It's quite common in India, especially if you have a heavy set patient or obese patient. So, spleen appears enlarged as well. Pancreas has fatty infiltration. The livers have raised echo texture, which means it's just like AKI or acute AKI on CKD. And so, no real, the ultrasound abdomen is not really helpful, right? So, you get additional investigations done. Dengue, malaria negative. Vidal is negative as well. Hepatitis A and hepatitis E are negative as well. However, ammonia levels, because this patient is very confused, it comes back 165, and now you're like, oh, is this patient in acute liver failure or what's going on? Again, you get cultures that are there's a sputum cultures positive for Klebsiella pneumonia, sensitive to tigecycline, aminoglycosides, fluoroquinolones, and intermediate to carbapenem, which is a carbapenem. And we see this right over here. And this comes back from the sputum. Okay, so you can say intermediate to carbapenems, sensitive to fluoroquinolones, sensitive to nitrofurantoin, colistin, polymyxin B, and resistant, however, to amoxicillin, resistant to zosa, to piperacillin, tazobactam, resistant to cefoperazone, and so this looks like probably not probably, this is ESBL. That may, we do not know this yet because it's still sensitive, no, intermediate sensitive to the carbapenems, but this could also have some component of showing some enzymes like of carbapenemase such as KPC, OXA48, or NDM. So then what diagnosis do we come to? Septic shock, possibly. Is it bacterial pneumonia from atypical pneumonia, or is it like obstructive jaundice with the Klebsiella from hematogenous spread? Maybe the Klebsiella came from the lungs and is now spread to the gallbladder, or maybe some cholangitis. Remember, when you have cholangitis, that won't show up. You may not necessarily see an obstruction or a distended gallbladder. That's because that's a inflammation of the bile duct, not of the bile of the gallbladder. So we consulted a GI surgeon for concern for biliary stasis, septic biliary stasis. He recommended to maximize medical therapy. Again, this patient had fluid overload. Again, after giving albumin, we had to give more Lasix, and they got better. So as you can see over here, this is a patient who swings easily right to left depending on how much volume you give. He started rifaximin and lactulose for the hyperammonemia, started on tube feeds, and advanced to soft diet. This patient responded very rapidly to medication. She had good response to therapy, rapidly came off pressors and woke up, mental status improved, and he started on aggressive daily physio and daily mobilization. She then had maybe aspiration due to feeding, as we moved her to semi-solids. She had questionable aspiration to feeds, for which we added IV clindamycin for additional anaerobic coverage. Remember, piperacillin tazobactam has pretty good coverage, but clindamycin works better in the lungs. She needed 2 liters of oxygen via nasal cannula intermittently, which got better as she started physiotherapy. Her kidney function slowly normalized, LFTs normalized, and GCS came back to 15 by 15. She was discharged 9 days after admission. She had normal kidney and liver function at that point. She walked home after regular physiotherapy. However, what we realized is on recheck ammonia just before discharge, it is 235, which is even higher than the ammonia level when she was quite sick. So she's currently undergoing hyperammonemia workup, a congenital hyperammonemia workup, probably due to carbamoyl synthase deficiency as a part of the urea cycle currently in OPD. And then finally, we come to our third case, which is an unusual case of pneumonia. It's not so unusual for the critical care world, but for the world where it sees less critical care patients, it's a little unusual. 52-year-old male who presents with chest pain, cough, respiratory distress, cough, fever. So pretty standard, quite not uncommon, especially in the winter. This sounds like, viral pneumonia, right? But however, on admission, hypotensive to 50 over 30, heart rate 123, respiratory rate 34, saturation 86% on room air, however, awake, alert, oriented times 3, making sense in significant distress, and temperature is about 100.3. Has a history of diabetes mellitus, coronary artery disease with a stent 1 year back. He was immediately started on BiPAP for dyspnea, and he doesn't have his old echo reports, but he said that he does not have some normal heart. He does not know EF or anything, but he says he has some heart problems. He was immediately given 500 cc ringer lactate bolus and started on noradrenaline infusion. We started empirical coverage with meropenem plus clindamycin. He was immediately admitted to the ICU, and stat labs are sent for. We send these stat labs, and because of his unknown cardiac status, rather than giving him more fluid, we decided to give him more colloid. We see over here this patient has normal kidney function on this side. However, slight low potassium, which is consistent with cardiac medication he took. However, has a high urea level with the creatinine that's on the upper range of normal, suggesting early AKI is fluid depletion at risk for acute kidney injury. However, he has normal magnesium level, so he's not hypokalemic because of low magnesium. Look at the X-ray, and it kind of tells you that what you have, right? This looks like a pretty big pneumonia on the right side. The heart is not particularly dilated. However, there is some evidence of little bit of fluid overload. You see enhanced vascular markings over here. This side is much more difficult to say just because of the inflammation. You're going to have increased vascular markings anyways. Labs come back. They're not too bad, right? White count 4300, platelet 1.6, hemoglobin 12.9. The urea is not too bad. It only goes from 47 to 51. Creatinine's gone to 1.8. So this patient looks like is getting the sepsis, or not the sepsis, but the organ dysfunction may not be responding as well as you want it to. CRP is 146, which is high. Albumin is 3.3, so not too bad. So nutritional status is probably not bad. LFT is not bad, normal. However, you get the ABG shows 7.47, so alkalosis. PCO2 is 26, so respiratory alkalosis. PO2 is 54, so some hypoxia, along with that base excess is negative 4.8. So a negative base excess means you have less base, which means you have acidosis. So a negative base excess implies likely metabolic acidosis. A positive base excess, when you have more base than needed, implies likely metabolic alkalosis. So probably this patient has metabolic acidosis, and we can see why over here. You have creatinine that is elevated, urea that's elevated, so probably renal origin. We order influenza PCR. Patient has positive troponins. On the on the card test, you send the troponin I, comes back a little bit at 0.18, consistent with septic cardiomyopathy. Sputum cultures are sent and are pending. However, after a day or two, influenza PCR comes back positive for H1N1, and sputum culture comes back positive for Staph aureus. So as you see over here, influenza A is positive, H1N1, and over here you have Staph aureus that you should sense when you see this sensitive to cefuroxime and resistant to cefoxitin. Consider them resistant to all cephalosporins. Okay, and this one comes back at MRSA. So sensitive to vancomycin, resistant to amoxicillin clearly, sensitive to imipenem, meropenem, but you don't use that, especially for MRSA against because you don't know. However, clindamycin is sensitive, linezolid is sensitive, fluoroquinolones are resistant, cotrimoxazole is sensitive, rifampicin is sensitive. However, when you have a severe patient in inpatient, we never use uh, rifampicin alone or cotrimoxazole alone for inpatients because they rapidly develop resistance. However, cotrimoxazole is a perfectly reasonable outpatient option. So, what do we have? This influenza pneumonia complicated by MSSA superinfection. Sorry, not MRSA, MSSA superinfection. Has AKI, hyperkalemia, septic shock, and because of the history of CAD, satisfies PTCA, we are a little bit careful with the fluid resuscitation. We changed our antibiotics from meropenem to doxycycline plus clindamycin based on the antibiogram. We added ostelamivir, which in India comes with anti-flu for influenza coverage. Cardiology was consulted and they recommend to continue maximal medical treatment, and this patient was discharged home after 4 days, responding very, very well to treatment. And with that, thank you so much. I look forward to seeing you all again.
Thank you, sir. Thank you so much for the beautiful talk. Now, I would request all our audiences who are with us, if you have any questions, please let us know. Meanwhile, I have already received a few questions. So, the first question is, in your extensive experience, what are some of the early signs of sepsis that often go unnoticed, and how can clinicians be more vigilant in detecting them?
the early sign, most patients don't come to the clinician right up front, right? They are at home. So the most common sign of sepsis that is missed, and this is commonly seen in elderly patients, is encephalopathy, right? Patient is sick, they're a little bit more tired, they're more drowsy, मम्मी को सोना है, पापा अब एक दो दिन से उनको अच्छा नहीं लग रहा है, वो लोग सो रहे हैं, ज्यादा सो रहे हैं. So the most common sign of sepsis that is frequently missed is their patient is more tired, more sleepy, more a little bit more confused, and they attribute it to the old age. That is why. Now, also, what happens is because that they're not tired, they're encephalopathic. What we say, they're encephalopathic. Their food intake starts to drop off. They're not drinking fluid. They're not eating food. So the next thing that happens is they get dehydrated very quickly. And the easiest way to check dehydration is the color of urine. So one of the few things that you can ask, when they go into the clinic, is what color of urine is. What is the color of the urine? And very often, the family may not know, but if they do know, that's an early sign your patient is dehydrated, right? And if your patient is encephalopathic, not a good idea to send them back home. They can't take their medicines, they're not going to eat, they're going to just sleep all day. And when they're lying down and not taking deep breaths, the next thing they're going to get, if they don't already have pneumonia, is pneumonia. Another thing is older patients tend to get UTIs more easily. So encephalopathy in an older individual, especially female, you have to rule out UTI.
Right, sir. Thank you so much for answering this. The next question is sepsis is known for its rapid progression nature. So, can you share some of the key challenges faced in managing sepsis and multi organ dysfunctions in the critical care setting?
So, good question, and you're absolutely right. Sepsis is an emergency. There is no two ways about it. Okay, sepsis is to be treated in the emergency room with the same urgency that you would treat maybe a STEMI, which is a myocardial infarction coming to the ER, or a stroke that comes to the ER. You have very very strict and time bound guidelines. The scope of this talk was just talking about some bedside cases, so I didn't put in the literature. But if you look at the literature and current guidelines, you have to give empirical antibiotics within 1 hour of suspicion of sepsis or a diagnosis of sepsis. Antibiotics within 1 hour. You have to start IV fluids, that is 30 ml per kg of body weight within 1 hour, and ideally to be completed within 3 hours. So you have up to 3 hours to complete 30 ml per kg IV fluid, which means for a standard Indian male of 70 to 80 kgs, that is 2.1 to 2.4 liters of fluid to be completed in the first 3 hours of admission. Not admission, presentation to the emergency room. Antibiotics is the first one. You want to take blood cultures before you give the antibiotic. So that means within the first 1 hour, you want to take blood cultures, you want to get blood tests started, and you want to check an immediate lactic acid level. Why? Lactic acid is an indicator of tissue perfusion. Okay, by tissue perfusion, it also means whether you are getting good perfusion to the general vasculature, or is there any focal area of the body or any focal tissue, say gut or intestines or muscle, that is getting low amounts of blood flow. Now when the lactic acid is high, you usually will give fluid, but you also have to see why is lactic acid high. There can be three main reasons why lactic acid is high. One, hypoxia, where there's enough blood. So you can have high lactic acid with normal blood pressure if your patient is hypoxic. Why? Insufficient oxygen supply will lead to anaerobic respiration, which leads to increased lactic acid. So hypoxia. Two, low blood pressure. Low blood pressure, insufficient oxygen and delivery to the tissue, you will have high lactic acid, and due to anaerobic respiration. Three, hypoglycemia will result in hyperlactemia, that elevate lactic acid, because again inability to perform aerobic respiration mitochondria due to insufficient substrate. And D, lastly, which we don't consider, is just sepsis itself causing mitochondrial dysfunction or cellular toxicity, will also cause lactate levels to increase. So these are the, so when you see these high lactate levels, yes, of course, give the fluid stubs if they're hypotensive. But if they're not hypotensive and they've got good perfusion, your capillary refill is good. Look for other alternate signs. Is it local tissue hypoperfusion, tissue you can't see? Like for example, gut ischemia is like having a heart attack of your intestine. You can't see it. Patient may be encephalopathic, will be complaining of abdominal pain. You don't know what is going on. You have given your IV fluid, blood pressure is now normal, oxygen level is normal, but lactate is high or still increasing. Then you start looking into these other areas where you can have localized hypoperfusion.
Right, sir. Right, sir. Thank you so much. Next question is, with evolving treatment modalities and interventions, what advancement in critical care have you seen that have significantly improved the outcome for patients with severe sepsis or septic shock?
So another great question, and there has it's not really technology that has improved the outcomes in severe sepsis, septic shock. It is more about the recognition that sepsis is an emergency and needs to be treated quickly and early, and along with the increasing adoption of guidelines and care, what we call care plans, where standardized care plan. So, septic shock, do point A, B, C, D, E automatically. And treatment starts in the ER the moment the patient comes into the hospital, correct? Or the moment the patient comes into the ICU. Treatment starts immediately. It is a protocol. Everybody in the ICU knows it. Your RMO knows it, your registrar knows it, the nurse knows it, everybody knows it. And it is standardized, it is delivered. Yes, once the initial treatment has completed, and then you're making decisions. Do we give more fluid, do we give less fluid? What is the heart function? What is the echo? Is it a heart failure? Then those things come around, and of course there have been significant upgradations in that as well. The use of ultrasound in the ICU has become far more widespread, where we're quickly able to diagnose what is the heart function, right there in the ICU in the first 2 hours, the first 1 hour or 2 hours of patient coming, instead of calling the cardiologist and waiting 6 hours, 8 hours, 10 hours, 12 hours, 24 hours later for the diagnosis. Now, bedside echo has become so much better. The training for bedside echo has become so much better, where every ICU doctor, you don't need an exact key. Is it 52.3% ejection fraction? You just need to say good ejection fraction, bad ejection fraction. That's enough, right? So, with the advancement in treatment protocols, increase adherence to guidelines, and the widespread availability of bedside ultrasound, I think those are things that have made a big difference to outcomes in critical care and severe sepsis, of course. And I can't discount our colleagues in the pharmaceutical sector and in the research world, who are constantly looking out and inventing and developing new molecules, new antibiotics to help overcome bacterial resistance. I think they are contributing massively, and they are often the unsung heroes who do not get enough credit for what all work they do.
Thank you so much, sir, for giving them their due credits. So, with
Of
that,
course.
moving on to the next question, and this is the last question for today, sir. Given the global impact of sepsis, what steps do you believe are crucial in enhancing early recognition, treatment protocols, and education among healthcare providers to reduce sepsis-related mortality and morbidity?
Wonderful question, and thank you so much. So, we can take a lot of learnings from the COVID pandemic. Remember, before the COVID vaccine came out, COVID was deadly. Of patients who presented to the hospital, if you were on the ventilator, 30%, 40% mortality rate. If you're admitted to the ward, 3 to 5% mortality rate, right? And we got vaccines. Everybody got the vaccine, and now you don't hear about COVID. You barely hear about COVID. And oh yes, there are some people who are immunocompromised, for whom it's still bad. But from COVID being a worldwide pandemic to now COVID being reduced to a seasonal influenza flu-like disease is is due to vaccines, and there are multiple vaccines available. So, for healthcare providers, ensure that your patients, especially your immunocompromised patients, take all their recommended vaccines. So whether that's a yearly influenza vaccine, the pneumococcal vaccine for the prevention of pneumococcal pneumonia or pneumococcal infections, the shingles vaccine for the prevention of herpes zoster, uh, then your meningococcal vaccine for patients who are have poor immunity or who have undergone splenectomy. So there are multiple vaccines available for the prevention of certain diseases. Those are absolutely essential to overall improve the quality of life. Then secondly, improving the overall health of the person, because like I said, by the time you turn up to me, it's too late, right? I can't rebuild your immune system that has been struggling for the last 15, 20 years. I'm going to have to treat you. So the prevention is the crux of the problem. So ensuring great nutrition, adequate nutrition, so low carbohydrate, high fat, high protein, with high amounts of monounsaturated fatty acids to help boost your immune system. Remember, eating and having a lot of antioxidants. Avoiding refined sugars, avoiding saturated fats, which increase in the amount of inflammation in your body and reduce the effectiveness of your immune system. Drinking enough water, regular visits to your doctor, and most importantly, exercise, exercise, exercise. Just exercise itself, just exercise in itself is associated with for every 25% improvement. If you are in the bottom 25% and you go into the middle 20-25% of the population in your exercise capacity, just doing that results in about a 30 to 40% reduction in mortality, all cause mortality, not just sepsis, whether from heart attack, stroke, getting hit by a car, falling down at home, having a hip fracture, knee fracture, anything. So it is nothing to do with, so prevention has nothing to do with sepsis. Vaccinations, yes. Eating a good diet, yes. Going to the regular doctor, yes. Making sure, keep your diabetes under control, your heart condition under control. But even before you get there, exercise and good diet, that is where you're going to make the difference. By the time you come to the ICU, to me, it's too late. You've already been in a car accident, or there's already a big event that's happened. Now we're just fixing the problems, we're just putting the bones back together, stopping the bleeding. Yeah.
Right, sir. Right. Thank you, sir. Thank you so much. So these were all the questions for today, and I would like to sincerely thank you for your valuable presentation. And yes, the case studies that you have shared along with your practical insights have certainly enriched all of the viewers' understanding on sepsis management. I'm very sure about it. And sir, thank you once again for putting your time and your effort in delivering such a meaningful session. So really looking forward to do another session with you. Thank you so much, sir. Thank you so much for your time.
Thank you so much. Thank you, Arpita, and have a good day.
Thank you. Same to you, sir.
And
Thanks to all our
everyone.
viewers. Thank you. Thank you all for all your time. Thank you.
Thank you everyone for taking time out and listening to me. I hope you enjoy your Friday and weekend.
Thank you, sir.
Thank you.